learn more about where we are in the COVID-19 world and what our future might look like. So welcome.
All right, thank you, Megan. Megan, I would say your lunch was not quite as good as we normally get for this. So we have a little bit of, in Jackson, Alabama, we don't have quite as much selections here. So
for sure, maybe some people got to enjoy their pretzels or their brownie brittle from the box that we sent.
So appreciate y'all being here, and I know you're eager to listen to our expert panelists. I get the chance to moderate another panel. Usually in our pain management seminars, I get to moderate a panel which has Dr. Harrison and Dr. Smith, and people have asked me what that's like, and I said it's kind of like doing a presidential debate between Biden and Trump. So my panelists today, I think it'd be a little bit easier to deal with. Now, it's a lot of fun because you get to sit here and pick some people's brains and try and learn from them. I did just get a text from Mr. Spock. He did say that Vulcan is undergoing a pandemic right now. And he did say, as a way of disclaimer, that you should be aware that what the panelists say today should sound scientifically accurate, but in all likelihood, there's a 67% probability that Monday morning at 8:30 it will be proven wrong. So we are living in an unusual world. Things do change rapidly, but we do appreciate their expertise. So I want to start off. My nursing home made it through the first wave of COVID very well. We had almost no cases. We got our first dose of Pfizer vaccine about 2 weeks ago. We now have 28 positive cases. Are we doing something wrong?
I mean, in all likelihood, no, not knowing sort of all of the interventions that have been undertaken at this point. I think, long-term care facilities, skilled nursing facilities, they're a captive audience that unfortunately is at the mercy of the surrounding community. And it's inevitable, unfortunately, with as much community spread as we're seeing right now, that it's going to make its way in. And with a captive audience indoors, it's unfortunately this easy to circulate sort of a situation. So I don't think the presence of infections is a failure in any way. I think the move to get vaccines in place is the single most important thing that we can do right now. And I applaud you guys on being able to do that so quickly.
So you brought up the issue of vaccines. So let me bring that up, because that does bring up an issue now. So most of us have gone through our first round of vaccines. So then we've had these huge outbreak in between our first and second dose. What is your thoughts about timing of the second dose of the vaccine?
There's a funny saying in infectious diseases. You ask 3 different ID docs what they would do in a particular situation, you'll get 4 or 5 different answers. I think that there's no right answer. I also don't think there's a wrong answer. I think if you look at the trial, they had people pop up positive between the 2 doses. And as far as I'm aware, they didn't halt the schedule for those patients. And so you can stay on the schedule if somebody's having a lot of symptoms from their active case. Maybe it's easier to wait until their symptoms have calmed down. I don't know that you necessarily have to wait the 90 days that's being recommended to start the series after having had a previous infection. But I think if you ask any number of people, you'll hear guidance along that spectrum.
Tammy or Melanie, you want to jump in on that?
Yeah, I would agree with Dr. McCarty. We've had this situation presented to us several times at the state where facilities will have their first round of the vaccine, and then there is a significant increase in the number of cases that they're seeing in the facility. And so they're trying to figure out if there's any association whatsoever with the outbreak and the vaccine, or if there's just a high level of community spread at the time. And with as long as all of the infection control protocols and standards remain in place while the administration of the vaccine is being given, there should be no association with the outbreak and the vaccine, or having people come into your facility to administer the vaccine to the residents and your staff members. As Dr. McCarty said, we are continuing to see spikes, especially over the holidays. When I looked at the data this week, we have seen a decrease in the number of resident cases and among staff, but from what I am reading, there is a forecast that we are going to see a spike in the number of deaths in the coming months. And so we just need to remain vigilant. And even though we are making progress with the vaccine, being able to administer that in real time, we just have to make sure that everything that we have been doing that we know is working is still in place as we move forward.
Tammy, any thoughts on the second dose of vaccination?
Well, our homes have received their first dose, and we did not see a spike in COVID cases. One of our homes have completed 2 doses. I actually have had both my doses, and so far we have not seen a spike.
So one thought between delaying the second dose is delaying it 90 days because obviously if they've had an infection, they're unlikely to get another infection in 90 days and save the dose for somebody else. My concern is more clinical. If they've already had a dose of the vaccine, then they have an acute infection, their antibody titers ought to be pretty high. And we've already heard that the side effects are going to be worse on the second dose. And I can just tell you my practical experience, my nurse who had acute infection, then waited her 90 days, when she got her vaccine, she said she felt like she had COVID all over again. So my real concern about delaying the dose is more about the side effects that these elderly patients might get if they're getting a dose 14 days. If they've already had a dose of vaccine and had acute infection in 14 days, when the antibody titers are high, you're vaccinating them again, are they going to have much more systemic reaction?
I don't think anybody knows the answer to that, unfortunately. And I don't know that, waiting longer will necessarily ameliorate those concerns down the road. If you wait 14 days, 2 months, 3 months, it does seem to be anecdotally a common sort of statement and experience, but it'll take a whole lot more sort of time and understanding and sort of knowing the serostatus of patients in advance to have a better idea of just how much more severe or prolonged the side effects might be.
So as far as rolling out for the nursing homes, those doses are designated, so there's no potential for the nursing homes not have the ability to get that second dose in. Is that correct, Melanie? Is there a protected lot for them?
Yes, there's a set amount of vaccines for each resident and staff member in long-term care facilities. And so we actually had this question on Friday about individuals who had their first dose, but then had an active COVID infection, and whether or not to delay the second dose or to wait the 90 days and then administer it. But with the amount that we have right now, it's only, you wouldn't restart your series of vaccine. I think what Dr. McCarty said, to go ahead and continue on with the second scheduled clinic that you have is going to be the best way to continue getting the full protection from your first and second dose. There is only 2 vaccines administered per person, so delaying or having to restart the series of doses, we just don't have the vaccine available to have more than just 2 doses per person.
So around outpatient, most of us are using the Moderna. Are most of the nursing homes getting Pfizer, or are some of them getting Moderna?
With our 3 homes, we received the Pfizer.
So that's what my nursing home has gotten.
Yeah,
So I
we
think
had
that
the
was
Pfizer.
something that got out. Okay. So it's my understanding, I mean, some of the pharmacists are doing that, and then there's a collaboration with CVS and Walgreens that are doing some of the nursing homes. Is that correct?
That is correct.
Yes.
So let's move on.
We have
Go
a
ahead.
few questions in the Q&A box. We'll jump to those real quick. Dr. Wagner says, please discuss use of I'm sorry, I'm going to butcher this word.
Nobody can say it right.
Somebody else please do that for me.
It's just BAM. Just say BAM. Everybody knows what it is.
Bamlanivimab. I don't mind fielding this one. I think all of these monoclonal antibodies, antibody cocktails, convalescent plasma. I think there's interesting data coming out using it as like a post-exposure prophylaxis and early treatment to avoid hospitalization. The biggest sort of dilemma in their usage, one, I think ideally they're studied a little bit better. There's a lot of implementation going on based on phase 2 trial data, and that's what's led to their emergency use. I think it makes sense. You give somebody antibodies very early on before the virus has had the time and opportunity to grab a foothold. I think the trouble becomes, how do you logistically set up a mechanism to provide an IV infusion of any of these things, whether it's bamlanivimab or a different product from Regeneron or Plasma or whoever. Are these people that are exposed and not yet infected? That's sort of one realm. Are they already infected, and sort of the infection prevention implications of bringing them into an infusion center that might be filled with all sorts of other patients versus having like a COVID designated infusion center. So I think the data is very interesting. I would like to see more to better understand the right patient population. I think the sort of difficulty with getting them out there, as much sort of resources and funds have been committed to buying up doses, is really how do you get those doses into people and doing it in a timely fashion so that it is actually effective.
Tammy, what about in your homes? Have y'all been using BAM on any of your patients?
We have in our home in Opelika, East Alabama, they've assisted us with that, and we've seen great results from it. So we've seen positive results.
So let's say you do have somebody you treat with BAM, then it's my understanding you should delay their second immunization vaccination for 90 days. Is that correct? Since they've already got antibodies, is it going to do them any good to get vaccinated? So they say they've had their first dose of Pfizer, they get an infection, you try to treat them with BAM. When are you going to give them their second vaccine?
Yeah, I think so. Again, nobody knows. I think the concern is if you have a bunch of circulating antibodies, will that potentially bind up the spike protein and prevent your own immune system from generating the appropriate response? And so, I think it's a similar consideration. There's not really an urgency to vaccinating them if they've just been infected. And with this hypothetical concern of could the passive antibody treatment limit their immune response, it's probably worthwhile waiting. But nobody knows for sure if it's actually going to impair their immune response or not.
A similar frame comes up when we have patients that have been on steroids, or they just, not steroids for COVID, but other things, or they come in to get their vaccine and their dermatologist just gave them Kenalog, which is going to hang around for 4 to 6 weeks. Is that going to affect the response to the vaccine? Is there any reason to wait?
Maybe. I wouldn't wait. No amount of any sort of immunosuppression would make me want to wait. We're recommending it for all of our solid organ transplant patients. If it's available to them, they should get it. Maybe there's decreased efficacy, but it's a whole lot better than zero.
So Dr. Hodge brought up they're being informed that a booster may be required later. Now I know the CEO of Moderna came out and says you might have coverage for as long as 2 years, but after you get the first 2 doses, it's a good question. So a year from now, if you do need a booster, would you need to get Pfizer again, or could you get Moderna? Or if the J&J's out and it's a one-time dose, next time, does it matter which vaccine you got a year out from now?
I don't want to dominate.
Sure.
I'm happy to offer opinions. I want to be careful not to dominate the discussion either there. I think, it's going to be tricky because I worry that we're not actually going to find out how long lasting the protection is, as people in the trials opt out of sort of staying as a placebo participant in the trial and get the vaccine when their turn comes up. We lose some of the power of these studies to tell us how long the protection lasts. I think, we use antibodies as a surrogate marker of saying whether or not somebody's protected from an infection, but it's going to be a whole lot more complex than that. And so my suspicion is the Moderna CEO is commenting from a longevity of antibody response. How, like, will he be proven true clinically or not? You know, comparison to like preclinical data, maybe. The suspicion is that, yeah, we'll need boosters. I don't think the brand of booster you get down the road will matter. I don't think anybody can really predict the frequency that it may be required. And some of it may be what is sort of the natural history of the coronavirus once you have true herd immunity, primarily ideally through vaccination, but some component through natural infection as well. Does the sort of, if we're preventing severe infections and infections become milder over time, how necessary will repeat vaccinations even be? I think those are all incredible questions that it's very difficult to try and anticipate an answer.
Melanie, what's your thoughts as an epidemiologist? So the thing we're going to have with the vaccines, when you think about boosters, is some of these newer vaccines are going to be different mechanisms. J&J is a different mechanism from the messenger RNA. So if you get a different kind of vaccine, are you going to get as much response? Do you have any thoughts on that?
I don't have too much to say about it, just because I just don't know a lot about how it's going to affect the immune response depending on the type of the way that the vaccine works with the immune system. I think we're still very early in the process with collecting vaccination data and the side effects and how it works with our immune system. And so we just have to go with what we know right now and then continue to do our best to make sure that people are engaging in the systems that are set up to, you know, report symptoms and to better inform the state and the CDC about how these vaccines are working in the general population and, you know, how it's reducing disease severity and transmission in addition to how long it's going to last. So these are still a lot of questions that we have about these vaccines. And like I said, it's just still too early to know what the next couple of months will be as we continue to see the population get vaccinated and greater amounts of people are receiving the vaccination, of where it will change things for us in the future.
So I have a question. Is the vaccine recommended for patients on Orava for rheumatoid arthritis? But it sounds like earlier there's no suppressive therapy that you would delay the vaccination for.
Yeah, not from my perspective. I don't think there's any guidance to withhold it based on any sort of immunosuppression.
So where they're on chemotherapy or anything like that, you think the risk of COVID is greater than the risk of whatever else they've got going on? Okay.
We have a couple of comments in the chat, Dr. Furr. You want to?
Okay, so Dr. Rump said we blame COVID on inpatients that are in stage for other health. So do we believe the results are tainted the number of deaths because they might have died otherwise for other things and happened to have COVID when they died? That might be a good epidemiological question.
Yes. Can you repeat the question? I'm sorry. I was trying to follow you along in the chat.
You've got inpatients that are in stage for other health reasons. I mean, obviously they're in their nursing home for a reason. So then we blame COVID for their death, although they were already there and possibly dying, might have even been on hospice. So is that tainting our results as far as how many people are dying from COVID?
Well, the way that the state is looking at long-term care deaths is we're collecting the data from the Alabama Health Statistics, the Center for Health Statistics. And so if the death certificate includes COVID-19 as a significant or underlying medical or underlying contributing factor, then at that point, we would go back into that patient's record in our surveillance system and mark that they died from COVID-19.
Okay.
So if it's listed on the death certificate, then that's how we're counting it.
Okay. So of course, a lot of us are all concerned with the low number of staff that are taking the vaccination, and that's been a huge issue. So one of the doctors mentioned that less than 50% of his facilities, and he's concerned with the options after you have the clinic the second clinic and you got new employees and new residents that are admitted there that have not been vaccinated. So I'm assuming by then we're hoping that Johnson & Johnson will be available and other vaccines, and there'll be more available. But any thoughts on that, how we can get more people vaccinated in the nursing home?
Go ahead, Tammy.
Well, I do know that the Alabama Nursing Home Association, they've all been working really hard in efforts to have these vaccines available and getting them to our private pharmacies that provide for our nursing homes already. And like you said, it's going to have to be something different than Pfizer just because of the temperature requirements and things like that. But they're working diligently to get that available to our homes. So I feel confident that that will happen.
And we always get this question. I don't think it applies too much in the nursing home except for staff, but any comments on staffs who are pregnant and getting the vaccine?
So I put a link into the chat box, and I think Megan just shared it with the audience. So Dr. Dion Odom is one of the other infectious diseases doctors here and does a lot of work with women's health and collaborates with our OB/GYN colleagues. And she has provided a lot of thought sort of around this. There's not any scientific reason for why an mRNA in this sort of lipid encapsulated delivery mechanism injected into the deltoid muscle could make it anywhere near the baby. And I think it comes back to the same sort of risk benefit discussion that is happening, right? The risks of COVID in the setting of pregnancy are worse than unknown and sort of not even suspected, but just sort of questioning the potential risks of the vaccine. And so I think in my mind, in the minds of a lot of others, it's sort of slants in favor of vaccinating, but that's just one more sort of point on this need to improve vaccination of all staff and sort of providing information and sort of improving getting whatever the right message is out to sort of improve the uptake and acceptance of the vaccine.
So we had a patient the other day who said he has all kind of shoulder problems, so he didn't want to get a shot in the deltoid and he wanted to get it in the buttock. My experience with how much soreness I had in my arm, I can't imagine what it'd be like getting that in the buttock. And I'm assuming all the studies have been in the deltoid. Is there any reasons somebody could not get the shot in the buttocks if they choose that?
I don't think so. I mean, all the same sort of dendritic cells that sort of provide uptake and immune response should all be present there too.
It's just amazing the kind of questions we're getting from patients, and I'm sure you're all dealing with that now too. Just incredible stuff because it's all new and it's all different. I think the Medical Association put out some important stuff too. Is somebody needs, now that we're moving more to the Moderna, the real critical thing is once you puncture that bowel, it's only good for 6 hours. So really your timing of when you give it to patients, and particularly if you're doing it as an outpatient, number of patients you've got coming in. So after 6 hours, that bowel is no longer any good. So that's something you got to be really, really careful about. Let's go back maybe for a few minutes to treatment, since we mentioned BAM already. So you have patients, they turn positive. We hear everything from using Pepsid to zinc to everybody gets a Z-Pak now, and they get steroids. Megan, do you have that slide you can pop up from the Medical Association?
Yeah, hold on one second.
So most of you have probably seen this. It was put out, and this, maybe scroll down for us a little bit. This is the guidance for treatment. And this is put out from Dr. Sag and Dr. Overton and Dr. Thrasher, some of the things as far as treatment. So there's a lot of stuff out there. So let's start down at the bottom. So there's no conclusive data using hydroxychloroquine or Vicodin, vitamin supplements B, C, or D, or zinc. Would y'all like to comment on that any?
Hydroxychloroquine, I think, has been studied to death at this point, and multiple studies in multiple phases of illness both from pre-exposure prophylaxis to post-exposure prophylaxis to active treatment and early outpatient therapy, it's shown no difference. The ivermectin data has come from it has in vitro activity, but the dose required to achieve that is something on the order of like 100 or 1,000 times what the human dose would normally be and would be toxic. And as much as, vitamin supplements and zinc have, while a shortage might increase risk for severe disease, there's nothing that's been shown that repleting it has any impact on clinical course. And I think, vitamin D especially, while it sort of places people at risk for a deficiency places people at risk for a lot of different things, it's not clear how much sort of repletion of that has an impact on any sort of acute illness.
So it talks about adjunctive therapy with ibuprofen and acetaminophen. We've run into some of our employees when they went to a university hospital. They were told under no circumstances after they got their vaccine were they to take Tylenol or ibuprofen because it would blunt their response to the vaccine. And I haven't seen that anywhere else, but they told multiple people that. Y'all have any thoughts on that?
So there's some data from kids about antipyretics and limiting their sort of the immune response to vaccines. It's not been replicated in adults. And if people sort of need some symptomatic relief from the side effects of the vaccine, if that's what gets them to take the vaccine, then by all means. There's not, like I said, there's no data in adults that it has any sort of untoward impact on the ability to respond.
Early on, Dr. Hassan talked about using steroids, and I think he made a point about that you don't use them just for 4 or 5 days. So here, point number 5: never use systemic steroids in the viremic phase, days 1 to 8 to 10. So trying to figure that out sometimes can be somewhat complicated, when to use steroids and when not.
So a lot of that, so the data for steroids is in people that are quite ill and have to be in the hospital. If somebody's not requiring oxygen or not requiring an increase if they're on oxygen at baseline, there's no data that's out there to suggest that steroids are helpful. It was the large UK study that first brought out the sort of frequent use of steroids in people requiring especially high flow oxygen and mechanical ventilation. In that study, in people that weren't requiring any oxygen, there was no benefit and the trend was actually towards harm. And that's why it's sort of this bolded and very kind of profound recommendation against in this document, is because there is some fear and concern in those people that aren't on oxygen, and especially if they're in the early phase, that you could actually make them worse.
So the other magic drug now is a Z-Pak. So tell us what a Z-Pak does.
I don't know that it does anything for this.
But everybody puts them on a Z-Pak now. So
people have gotten Z-Paks for a lot of things over the years.
all right, thanks. Megan, I think you can take that down. Thanks so much. We appreciate that. So Tammy, would you like to highlight anything different you're doing in your homes as far as early treatment or as far as managing your patients?
Well, I mean, really, the key for our success, I think, if we can call it success, has been, just early detection. And that we've had the availability of the rapid test, and that has been so important in identifying the residents or our employees who have COVID, isolating early. So that basically that's been very important for us.
So do you rely solely on the rapid test, or do you confirm with the PCR?
It all depends. If it's a rapid and it's positive, we just treat it, as a positive. If it's negative and they're having symptoms or they've been exposed, then we will follow it up with a PCR.
Yeah. And is there any reason to retest for that 3 months?
We do add them back to the list after 90 days.
Okay. But other than 3 months, there's no real reason to retest before 3 months, correct?
Well, if
Unless they get
somebody's,
symptomatic.
yeah, if somebody's symptomatic or they've been exposed, we may retest, but usually it's within the 90 days.
So I think one of the things that we're all dealing with, our hospitals are full. So we're having to treat more people in the nursing home now than we would normally because the hospital beds are full. And even in the hospital, if we have to transfer them, half the time we're having to transfer people out of state. So I think the BAM's probably going to become more important over the next few weeks, trying to treat people and get them before they get to that severe stage. When do you decide to get a chest X-ray? Do you do it when everybody has a call for fever, or what makes you decide to get a chest X-ray?
Well, basically, if we have someone who starts showing symptoms, we just go ahead and start with the baseline labs and a chest X-ray, just to rule out. Of course, we're swabbing for the flu to rule out flu, and the COVID as well.
So Melanie, what's the incidence in flu of the state right now, as far as flu A and B?
Caught me off guard. I have not looked at the weekly influenza letter this week. I am so sorry. I could probably pull it up, but
It's pretty low right now still, right?
Right now.
But it's still pretty low, right?
Yeah, we're you know, we want people to keep flu in mind. There are things that are other than COVID, believe it or not, that are still circulating and that we still need to consider when somebody does become symptomatic. We do host long-term care office hour calls where we did talk a little bit about influenza and COVID and when you would need to test for influenza, when you would test for COVID, and then depending on the testing platform and the result, when you would reflex and stuff like that. But it's still remaining low, and I think that's because of all of the infection prevention and control protocols that we have in place for COVID that we would have obviously not had before last year. And so I think that has contributed greatly to the numbers in the cases of flu that we've seen so far.
What are your thoughts about anticoagulation and when you decide to anticoagulate somebody? Is that only for the more severe hospitalized patients, or is there a place for that in long-term care? Anybody can jump on that.
I'd be curious to hear from Tammy if that's something that they've sort of looked into and have thought about in the outpatient setting or the long-term care setting.
Well, I mean, we certainly have used some anticoagulation, you know, in the long-term care setting. I think one of the things that really benefited us well was that we were hit early in our home at East Alabama, you know, in Lee County at Arbor Springs. We were hit end of March when we really didn't know what had hit us. And we had our nurse practitioners there on a daily basis. They were seeing, you know, the folks with COVID and then the ones who didn't have COVID. And so we had two nurse practitioners. One would go to, let's say, the COVID unit. The other would go to the clean unit to make sure that, you know, no one was experiencing symptoms or maybe something. Because at the very beginning, a lot of our residents who tested positive were asymptomatic. I mean, we had one gentleman that went out to East Alabama that tested positive, and we got a call that he was positive, so we tested our whole building. And with that, we found, you know, over 60-something folks who had COVID that were asymptomatic. So the nurse practitioners being on board, but yes, they have used some anticoagulation. Early oxygen was important, and just the baseline inflammatory labs to see the progression and what needed to be done. East Alabama was full, and so we were sheltering in place. I think that, you know, the ability for the nurse practitioners to be in our building was monumental. And then we got some help from, you know, a hospital because we couldn't take care of everybody. We didn't have the staff because our staff started getting sick. So I feel like, as far as like the nurse practitioners being there and the physician involvement was so important. And so, we handled it the best we could. And I think we've learned a lot, 10 months later in that the baseline labs, inflammatory markers, the chest x-rays, early oxygenation, identifying COVID early, isolating, quarantine people who are coming into your home. You can start taking admissions. I mean, there were a couple of months where we couldn't even, we couldn't take admissions. It was because we didn't have anywhere to put them, or the staff to take care of them. So, we did try the Plaquenil. It was one of those trying times when you were doing whatever you had to do. And I am proud to say that, we do see great results with the monoclonal antibody treatment and just everybody being on board. And I think, we are still fighting COVID, but one of the things that worries me the most is the recovery process. COVID has affected the residents, everybody differently, and the recovery process is looking different for our residents as well. It's taken months for the recovery. And so now more than ever, we really are relying on our physicians and our nurse practitioners just being there and being on board. It's really all hands on deck.
So how do you decide which patients get BAM or the monoclonal antibody?
Well, that's up to the physician. And of course, they have to meet the criteria that's there in order to receive it. And then it has to be within 72 hours of symptoms and a positive result. And then East Alabama has assisted us in administering that.
Yes, and so far the transfusions, I mean, you have to monitor them pretty closely, but we've not had any problems. People seem to tolerate it very well.
Right. Yeah. And that's what we're seeing with our residents as well. They're tolerating it. And when they come back to us, I mean, again, they're going over to East Alabama. Now, this is something we are looking into administering in our facility. And I've talked to the Board of Nursing, and there's no reason we can't do that. So that's something that we're looking into.
I think the difficulty for us is, and probably most of y'all, is just staffing right now. You're staffing just and that's the reason we're having to send them to the hospital, and the hospital's kind of overwhelmed too. But the nursing home even more so, and they just don't have the staffing to sit there and monitor somebody while they're getting the infusion. So otherwise, I think we'd be doing it much more aggressively.
That's right.
Dr. Yates made a comment about the anticoagulation. He said, we have deaths in the nursing home that were compatible with embolic etiology. So our protocol was if they had pneumonia, then we anticoagulated for 2 weeks.
Any thoughts about how long you need to anticoagulate if they are?
None.
I mean, that's the real mystery. And that's the real mystery. Who do you anticoagulate? Once you anticoagulate, how long do you anticoagulate them? Of course, I guess part of that's how long they're more immobile than all. So that's probably part of it.
And there are some clinical trials that are ongoing to try and answer this question of just how helpful is anticoagulation, what is the right patient population, what is the right duration. So hopefully we'll get some answers from some of those studies soon.
So a patient has COVID pneumonia in their chest x-ray, and it appears that it often takes quite a while for that to resolve on their chest x-ray. If they're doing well, is there any reason to repeat their chest x-ray, or is there any thoughts on what you should do as far as follow-up?
I don't think so. I think as long as symptoms are improving and they're not displaying any sort of evidence of worsening or recurrence of fevers or cough or something else, I would think you would want to see some sort of clinical change before prompting re-imaging and reevaluation.
So we're getting some patients going to the hospital, so they're getting the remdesivir IV, so they're getting the 5-day dose. So sometimes when they're not clinically responding, some doctors will give them a second 5 days. Is there any data behind that?
So the original trial that showed that there was efficacy with remdesivir was primarily a 10-day course, and it was the second study comparing 5 and 10 days that didn't show a difference. I know early on here what we were doing would be 5 days for those patients that were on the floor and just getting nasal cannula oxygen versus 10 days for those that required mechanical ventilation. I think like with a lot of antiviral medicines, the key is getting it in early and quickly before it sort of morphs into the inflammatory phase. So my sense is that the benefit that you're going to see is going to be in those first 5 days. It's not likely that there's going to be any harm from extending it out to 10 in people that have had less of a response, but you're probably not going to gain a whole lot more from that next 5 days.
So Melanie, have you been having some kind of conference calls with the physicians? Somebody mentioned that. Were you giving that information?
Yes, yeah, we have long-term care office hour calls on Thursday at 11:30, and it's basically just a platform to have nursing homes join for 30 minutes, and we share information from the CDC, any new updates or guidance regarding infection prevention and control. We review testing guidelines and requirements, anything that has come out from CMS regarding visitation or any updates to their memos. This is originated from a collaboration with the Alabama Nursing Home Association and the Alabama Department of Public Health. And back in May, we had the CDC come and visit with the Healthcare Associated Infections Program. They were providing support to states that were needing help back at that time. And at that time, there were outbreaks in pretty much all of our nursing homes. And so they showed up. It was a team of 3, and we visited 25 nursing homes across the state. And from those visits, you know, we wanted to continue to provide support in a way that was going to be helpful because of the ever-changing guidance and everything that was trying to be implemented in a timely manner, and just trying to get a grasp of what should and should not be done at that time managing an outbreak. And so we collaborated with the Nursing Home Association, and then we also invited Health Provider Standards, which is our state regulatory agency, and they will sometimes present on the focused infection control surveys that they've been doing and what they're seeing in nursing homes and what they're getting cited for, really focusing on the infection control aspect, because that's where obviously they're, if you're able to identify gaps in your infection and prevention and control program, you're going to be able to keep the infection out of your facility. So we've just, this is probably the 10th month that we've been doing this, and so it's worked out really well. We rotate among each partner. So like the HAI program will have the first week, and then the nursing home will present, the Nursing Home Association will present, followed by Health Provider Standards, and then lastly, Alliant Quality, which is our quality improvement organization. We'll share some resources about NHSN reporting or any infection control guidance that they have that they've been working with facilities to implement.
So what time is that on Thursday?
It's at 11:30, and it's a
Okay.
30-minute call until noon.
Can you get that information out where Megan can all the other doctors join in on that?
Sure, yes, that would be great.
Yeah, just send it to me and I can send it out to everyone.
Will do.
So Charlotte asked how many nursing home patients have been vaccinated so far?
So our immunization division is collecting this information, and I know that we are working to have this information on our dashboard, same area that you would go to get the COVID-19 risk indicator dashboard. And I think that they might be breaking it down by long-term care facilities, but I'm not 100% sure. But that is something that we are posting publicly on our webpage, the number of people who've been vaccinated in the state.
What do you think as we go forward here in probably the next 2 to 3 weeks, we should have, most of all should have had their second doses of vaccine in there, but we still have a fair amount of staff that are not choosing to be vaccinated. Do you see a peak anyway soon as far as where we're at in the pandemic?
You said, are we
Did you see-
anticipating a peak?
Yes.
Well, I think that we're still seeing the peak from the holidays. We're just coming out of that right now. We're starting to see a slight decrease in the number of cases, but you know, we still don't know how long the vaccination is going to protect us, and so we still, I don't anticipate to see a peak, but at the same time, I don't know how well people are going to still implement everything that we've been doing in the past now that they've already gotten their vaccine, and they might think that they can, you know, kind of let their guard down and you know, gather with people and not wear a mask or anything like that. And so it's just hard to tell when there is going to be an anticipated peak, because it's ever changing, and people are under, oh, thank you. Thank you for bringing that up. But as the vaccine is getting administered, I mean, we do hope to see a decrease in the number of cases, of course, but we just don't know if there's going to be peaks associated with, you know, people kind of letting their guard down and not doing everything that we have been doing to keep this from spreading.
So one of the issues I think the health department is concerned about, because with these mass vaccination clinics, they've been kind of slow getting the data into the dashboard. So it makes us look like we haven't given as much as we actually have.
Yeah, that's always an issue when new programs are being implemented, is making sure that people know how to report and getting validated in those systems, and working with their health information technology support to be able to send those files to the Alabama Department of Public Health. We saw this when the point of care machines were distributed. There was a lot of issues with reporting and making sure that the files were validated so that we could get that information and turn it into an electronic lab report. But that's something that each clinic is going to get set up here soon, and the data will start to flow in. But it is a challenge as new things are implemented to make sure that people know how to submit the data and that they're submitting it accurately and correctly.
So they did make a big deal about it, but this, you know, when the vaccines first came out, they were saying, you know, you get the Pfizer exactly in 3 weeks, you get Moderna exactly in 4 weeks. So then I guess it was Monday or Tuesday, CDC kind of relaxed that and says, as long as you get it within 6 weeks. So there wasn't a lot of publicity about that, but they did kind of relax the guidelines as far as how long to get the second dose.
Yeah, I think that's sort of, they don't want people to like not go get the second dose just because they can't make it in the 3 weeks or 4 weeks, whatever, depending on the vaccine. It's interesting. So the country that's sort of been most effective at rolling out vaccines so far looks to be Israel. As far as like the number of people vaccinated per 100,000, they're well ahead of the rest of the world. And they're seeing a little bit less protection from the first dose than was reported in the clinical trials. And so I think, you know, it's an important point. Like, we should recognize the first dose comes with protection. It's probably not as good as the trials say. Nothing is ever as good as the clinical trials show. And as best as we can, we should stick to the timeframes studied and not intentionally delay, I think. Because that is sort of opening up this window of potential opportunity to get caught between doses.
So what would be the maximum time frame for whatever reason they just don't come back and get their second dose, nursing home or outpatient, whatever? What would be the maximum time you would say, hey, you need to start over and get another first dose?
Whatever answer I gave, it would be a whole guess. And I'll freely admit that, I think, we just don't know. I mean, this type of vaccine technology using mRNA in the delivery system it's novel from the standpoint of how sort of widely being given. These aren't the first time they've been studied in trials, but it's the closest anything has come to truly being approved and out in the market. And honestly, it's not even actually there yet. We are still operating under an emergency use. And so who knows, I think if you think about it in the setting of the immune system, you've exposed the immune system once. The timing, like just getting the second dose is what will provide that higher level of protection, and delaying it just delays the amount of time that you achieve that. But I don't know that you would actually have to start over.
And I guess the question will be, if with us soon getting the Johnson & Johnson approved, if for whatever reason they didn't get their second dose, and it's been a long period of time, would you give them their second dose of Pfizer and Moderna, or would you say, hey, let's just get the J&J and get the one-time dose?
I would give them whatever they're willing to take as soon as they're ready, willing to have it.
Okay. So Tammy, any other thoughts about what y'all have done in your nursing home as far as taking care of patients and managing patients, and what you're looking forward to going forward?
Well, I think basically now is just focusing on getting people vaccinated and restoration from, preventing and restoring for what COVID has, tormented us with for the last 9 to 10 months. Just vaccination, restoration, recovery.
So Dr. Smith brought up a good point about encouraging the physicians to meet with your staff and educate them about getting the vaccination. Actually, in my nursing home, I sent out a letter to all the staff, letting them know I was taking the vaccine. So every doctor I know is taking it. So you need to let the staff know that you think it's important enough to take that, and hopefully that will encourage them to some extent. But there is there's all kind of rumors and thoughts going around out there, and people are waiting to see how many problems people have and that kind of stuff. So, getting the staff vaccinated is really a key if we're going to protect our people there. We've got to get the staff being willing to be vaccinated. So that's real critical. Melanie, any thoughts going forward as far as what we're looking forward in the next few months?
Yeah, as far as the vaccination goes and staff, the issues with staff getting vaccinated, if you haven't already seen the CDC long-term care toolkit, they do have a lot of resources and infographics and FAQs for staff that are having concerns and just hesitant to take the vaccine. And so just continually reiterating that information. And if somebody declines, have programs set up in your facility that still encourage and still are talking and keeping vaccination at the front line, and kind of in everybody's mindset that this is, a small step forward in this dark tunnel that we've been in the past year. And this is our small little light that we're able to see. And I just think moving forward, we are making a lot of progress, and we've made a lot of progress in this past year, but we just, must continue to do everything that we know is effective and working. And so just staying hopeful and hoping that everybody just works together and sticks it out until we see the end.
And it is the Medical Association, if you are members, you should be getting emails at least once a week, maybe twice a week, that really give some good updates, just like we showed you earlier. So if you're not getting those, let us know. But there's some really good up-to-date information there. Charlotte asked the panelists if you could do anything, how would you change the nursing home facility and other policies with us dealing with what's going on? Any thoughts of anything we should be doing different?
You know, I think that the recommendations and the requirements that are out there right now has helped us to be able to identify infections early and perform surveillance testing on staff. And everything that we're doing now is all that we have and that we know is going to protect us until we have everybody who gets vaccinated and we can kind of take a step forward in that direction. But as far as changing anything that's already being implemented, I think that you all should just continue to do as you're doing and doing everything for early detection and isolation and cohorting and you know, training. I think that's been something that we have noticed is lacking in some of these facilities. You know, there's people who manage infection prevention and control programs, but they also do many other things. And so it's hard to have somebody who's dedicated to conducting surveillance and making sure that outbreaks are mitigated. And so I think staff training is something that we can focus on in the next couple of months. We'll be working with CDC to implement Project First Line. I'm not sure if any of you have heard about that, but it's basically a national initiative for all frontline healthcare worker staffs to have the basic level of infection prevention and control knowledge as far as hand hygiene, and especially in the long-term care and dialysis settings. They have specific modules for each of those healthcare settings. And so just working with your staff routinely to just make sure that they have the knowledge that they need to be successful and to take care of the residents in these facilities.
Todd, any thoughts about anything out there that might is on the horizon that might be effective as far as treatment? I know there's a lot of investigational studies going on now. Is there anything you're excited about or you think's got potential out there?
Yeah, so there was actually a press release yesterday about colchicine potentially sort of reducing the need for hospitalization and potentially even mortality. So I think that's what a lot of us would like to see, is something in the outpatient setting, like being able to treat patients once they end up in the hospital is good and helpful. An ounce of prevention is worth a pound of cure. If we can keep them from ever having to come to the hospital, that would be even better than what we currently have. So all we have at the moment is the press release that says that maybe there's some benefit from colchicine. To what degree and how solid the evidence is and the data is to support it, we're all kind of waiting to see at the moment. Beyond that, it's still a sort of flurry of investigating the repurposing of existing drugs to try and find treatments. And the success from that, unfortunately, has been limited. And so we've got vaccines, and while supply is limited and demand from a sort of whole community standpoint outstrips what we have, it's going to be far better than any treatment, anything on the horizon. And so vaccinate, vaccinate, vaccinate. PPE works. Wear masks, wash your hands. You know, again, if you don't get sick in the first place, you don't have to worry about the treatment. And so it's the vaccination question and hesitancy. You know, I think we just have to recognize that shaming people doesn't work, and we just have to be ready and open to listen to their questions and concerns and be ready to discuss. You know, I get messages from friends and family asking questions about it, and I just listen and provide my honest opinion. And the more we do that, the more as time goes on and people see that nothing bad is happening from getting the vaccine, or very rare bad things, if you think about some of these allergic reactions that are happening, hopefully acceptance goes up.
So let's go back to that. We got a couple of minutes. So, you know, you've had some people have some mild reactions to the vaccine, the first dose. Who would you not give, short of some having an anaphylactic reaction? Like I had one lady, her lips swelled up, but responded to Benadryl. who would you not give who would have a severe enough reaction you say, I wouldn't give them a second dose?
I don't, so, I mean, I think as long as it's in that realm of what sounds like an immune response, and so I had the Pfizer, I had both of my doses. Both times I had an entire day's worth of body aches, fever, fatigue, and it was miserable. They lasted a day and it was done. And I think as long as it falls into that sort of spectrum, regardless of severity, you know, if it's managed as at home and taking Tylenol, ibuprofen, or whatever else, then I don't see any reason why I would hold off on giving them the second dose. You know, if they have an anaphylactic reaction from the first dose, then, you know, that's somebody that maybe is best to wait and not redose and wait for a different type of vaccine. There is still protection from one dose. It's not ideal. It's less than, you know, what you get from the second dose, but they're not without anything.
And you know, some people have pretty significant reactions, which makes me wonder if some of them already had covert COVID and they didn't know it, and their antibody levels are already high, and that's why they reacted so much. And
yeah, no, I think it's a great question.
And you've been infectious disease, you probably had it and didn't know it probably.
Who knows? I never got my antibodies checked beforehand.
That's kind of the way I was. Don't ask, don't tell, you know. So, all right, good. Well, thank the panelists.